topic is essentials of COVID-19 testing, what anesthesiologists, surgeons, physicians, and all health workers should know. So let me quickly just introduce the person chairing this session. We have with us Major General Dr. Abimbola Amosu, a retired general but not tired, a consultant hematologist by our own rights. We are happy that you are chairing this session and should be moderating this session. So please bear with us, all of you that have joined us. So let me give it to her to introduce the panelists and start the session, Ernest. Thank you very much. So you have the floor, ma.
Good afternoon, everyone, or good morning or good evening from wherever it is you're joining. It's very impressive that we have people from all over the world, and I think that is a good start. This is the first webinar in a series that is being planned for clinicians and pathologists to interface. And I think we need to commend the organizers, and I'm sure at the end we'll be able to have a good engagement. For everyone, please mute. You're already automatically muted, but for the panelists, please stop your video during your presentation so that it will be easier, or less bandwidth, and people will be able to follow better. This afternoon, we'll be discussing the essentials of COVID-19 testing, what anesthesiologists, surgeons, physicians, and indeed all health workers should know. And then what's the very important role of the pathologist in scenarios that may seem simple or those that are perplexing. This webinar actually came out with two scenarios that were supposed to be considered, and I'm sure when we look at them, we find that they're very interesting and would also give a good perspective on what we expect to be done or what we as health workers should know. We have two pathologists presenting to us today, and after that we'll have three panelists from other specialties in medicine. Like has been said, we have anesthesiology, clinical microbiology, and neurosurgery. Webinars, participants should also note as we go along, you can please put your questions in the Q&A box, and they will be treated properly. We have the two pathologists who will be giving us the presentations. Dr. Hakim Lawal, who is a consultant chemical pathologist at the National Hospital, Abuja, Nigeria, and he's also the National Secretary of the College of Nigerian Pathologists. We also have Dr. Philip Nwajiobi Princewill. Dr. Nwajiobi Princewill is a consultant clinical microbiologist at the National Hospital, Abuja. He's also the Secretary of the College of Nigerian Pathologists in Abuja chapter. So we also have, we have secretaries of the national and also a very strong branch or a very strong chapter who will be giving us the first two presentations. Thereafter, we'll have the panelists, and at that point, I would also introduce them so you know we have a very eminent group giving the presentation today. Dr. Lawal, please, I think you can start.
My name is Dr. Hakim Lawal. I'm the current National Secretary of the College of Nigerian Pathologists. I'm a consultant chemical pathologist at the National Hospital. I'm also visiting consultant chemical pathologist at the Federal Medical Center, Jabi. The second speaker is Dr. Princewill. He'll be introducing himself at the start of his own session. So we had two scenarios in the advertisements that brought you here. And that was a 40-year-old woman who had been booked for elective CS that was rushed to the emergency unit on account of bleeding PV. Evaluation revealed that she had abruptio placentae and was being walked off for emergency cesarean section. Her height is 1.5 meters and the weight is 92 kg. There was history that she lost her last baby 24 hours after delivery. Birth weight was 4.6 kg. That was a big one. of course, we might be looking at gestational diabetes in this woman already. And there was no other remarkable history from her. However, on further probing, you know, the relative that brought her talked about the fact that she lost her husband a week earlier and that they both just jumped from the UK. And so you can see the COVID-19 diagram there. We are in the COVID-19 era. I think the second scenario too is kind of similar, although it's another. It's a 14-year-old male rushed to the hospital on account of accident that just occurred, an accident. And you found out that the patient was unconscious when you evaluated, and you suspected splenic rupture and a closed femoral fracture. You know that the patient requires urgent stabilization, including surgery, before you can refer to the regional trauma facility. But you also learned from the relatives that the boy just returned from Kano, where he worked as an Okada rider. And of course, once you hear Kano, we know what's going on in Kano right now regarding community transmission. So COVID is in the air for this particular scenario too. And the question was, what are the best lines of action as the attending anesthesiologist, surgeon, or physician, or the health worker in the above scenarios? What will be your best next lines of action? We've provided some possible lines of action. We think this particular aspect of the discussion, we look at it after the presentation, of course, when we've already laid down the essential of COVID-19 testing. But the first, you can decide to call the NCDC, or we know the NCDC, immediately to come and take sample and test for COVID-19. Well, you know, we all know the NCDC have their criteria, which you must fulfill. There's no questionnaire, so there are some delays because of, you know, but they can respond. Another option is to admit a stabilized patient while you wait for the RT-PCR test from NCDC. But can we? The time is precious in these two cases. Can we offer that? We can also proceed immediately to the theater to save the life of mother and baby, or in the case of that boy, you know, take him to theater and, you know, trying to see how you can stop any kind of bleeding. But the question really is, how safe can we be in this particular era? Are we being? We have to look at the people that are going to that theater, the surgeons, the anesthetists, the runners, the theater nurses. How safe are they? We know theater procedures are a bit invasive and they can be aerosolizing, which is one of the risk factors for spread of COVID-19. We can decide to screen patients using any available rapid COVID-19 test kits before going to emergency surgery. Maybe if we want to just survey. We know that some facilities may be doing this, you know, quietly, but we need to look at the science behind rapid tests and how we can best utilize it if that's an option, so that we can at least have an idea if there's a condition or, you know, and all that. I think the last point here talks about discharging of the patient, mother and baby here, 6 hours post-delivery. Of course, if it's a boy too, 6 hours post. You want to quickly get rid of any cross contamination or infection. You know, you have patients in your hospital. You don't want your hospital to become closed down due to it being a source of, you know, another index and all that. So, well, this we're going to discuss at the robust interactive session. We know that the NCDC has been doing quite a lot. As at the 31st of May, they had already tested more than 60,000 samples, so it's currently 60,025, and 9,855 confirmed cases are reported. We know that Nigeria, we're a country of about 200 million and above, and what they are doing is what you call smart testing those with symptoms and those that are really, those that have a high risk. But we know that in this phase of community transmission, the testing does not really give the real picture of what's out there in the community as of today. I actually brought this out because this particular day, 30th of May, 2020, had the highest recorded confirmed cases, 553 cases, and like telling us that community transmission is real now. Nigeria's graph has been a bit going up and down. But we all know that it has been reported in the press regarding the wide explosion of COVID-19 infections in Nigeria. People don't take it serious. People are going about their business. Yeah, the lockdown, we know how the lockdown was, how effective or ineffective it was, and all that. But I already just dropped this I brought this from a WhatsApp. People are not taking some of these measures seriously. I just passed my landlord without him recognizing me. These face masks are really working. We see a lot of people now wearing face masks. Many wear it on their chin. Some actually remove it to cough, and take foam and all that. So we know. Well, let's come home to some news about health workers. This about some weeks ago. In a particular week, infection among health workers doubled, in fact, more than doubled, from 40 to 113. That's very alarming. We all know we cannot close hospitals. No matter what happens, hospitals must remain open. And we're all at the front line, be it you are the attendant working in the hospital, be it the doctor, the surgeons, the nurses, and all that, because patients will keep coming to the hospitals. I like doctors. I got this from the Association of the NARD, that's the Nigerian Association of Resident Doctors. And decided to keep a tab, just like Density is doing, on a number of medical doctors that have been exposed. And you can see that this is even dated data. This is 13th of May, 8 a.m. And you can see number exposed is 744. Total confirmed cases 129. And those that are recovered, 14. And sadly, 7 doctors have died. 7 doctors have died. 7 doctors have died. Health workers is in the news everywhere. They are testing positive. They continue to test positive. So how do we? My colleague will be talking about Dr. Prince will talk about the virology and the molecular diagnostics of this COVID-19. You hear of coronavirus, COVID-19, SARS-CoV-2, and SARS. All the things. I think Dr. Prince will do justice to that in the next at his own session. And so, just to end this particular intro, the outline of the presentation that we'll present shortly, we'll talk about COVID-19, the novel. What do you mean by a novel? What a novel coronavirus? What is novel about it? We'll talk about the diagnosis, especially from the laboratory's perspective. How negative are those negative tests coming? How negative are they? What are the factors that can bring about a negative sample? How positive are the positive samples? I'm talking about the molecular tests coming out and all that. We'll talk about them. Testing modalities, of course, the molecular, which is the gold standard RT-PCR. There are also antigen-based diagnostics. Of course, there's serology where you do antibody-based testing. Then I think in the interactive session, COVID-19 surgeries and other medical decisions, we'll see how diagnosis can help improve or safeguard health workers so that they can take safe decisions for especially the health worker who is at risk. Then we'll talk about the keynotes and we'll try. But I think we should try and wait for the interactive session. Because I believe that we're going to share knowledge. Whatever practice you do as a health worker, as a surgeon, as a doctor, and we try to look at it from COVID-19 diagnostics. All right. Next speaker now is Dr. Prince, and I think that this is a slide, and he will be taking up his own session shortly. Thank you.
We are going to look through, because what we are looking at today is the issues of COVID-19, particularly how a lot of our first responders, physicians, surgeons, what are they going to do? Because COVID-19 or no COVID-19, patients are still going to come to them for care. And it's important that as they treat these patients, they also avoid exposing themselves unduly to any infectious hazard while providing the basic service they are meant to provide. And also, they should also act as a means of keeping the infection within check and further spread. So we'll try to understand what we can about COVID-19 by looking at the coronaviruses, update ourselves on the outbreaks, and then we'll continue down. So just to remind ourselves, currently we have over 6 million cases, and as of yesterday, we are close to 400,000 deaths, and it's still spreading. And one of the challenges we are having is how do we diagnose this illness early enough so that those who are infected, we can, prevent them spreading the infection to others. And also, we know the earlier people have access to proper health care, the better the prognosis in the long run. Now, COVID-19 is caused by the severe acute respiratory syndrome coronavirus 2, and usually presents with high fever and respiratory tract syndromes. It's a highly contagious virus, mainly spread through respiratory tract droplets and direct contact between individuals, or also indirect contact when individuals come in contact with where the virus has been dropped. For example, somebody expels to the respiratory tract and leaves behind droplets on a foam mat, and somebody else comes in contact with it. The WHO has been clear in the message it has sent. We need to improve our testing capacity because it's believed that testing is a major bulwark for us to be able to contain it. And the fact that because we need to continue still giving healthcare, we cannot shut down our societies permanently, we quickly have to bring on board diagnostic methods that are of not only that they are sensitive and specific, but they also have to be available at critical care areas. Now in Nigeria, we are having what we call community transmission. So it's very difficult when you have community transmission, which means that the issues of where people's travel history is not so relevant now, because a lot of the time people are picking up on people who you cannot actually say they came in contact with someone who was high risk. You can't say they traveled out of the country. So it means everybody is a potential case of COVID-19. And this is something physicians must bear in mind. Now, the causative virus, the coronaviruses, first, they were described in 1949, and then they were named in the late 1960s. And even before we started having, in the 21st century, when we started having epidemics, we used to have coronaviruses that caused the equivalent of common cold, about 15% of the common cold then. And this was usually in the temperate region. But it is believed that even though majority of coronaviruses are viruses that affect other species apart from man, for example, birds, mammals, and reptiles, but because they have the ability to undergo genetic drifting, zoonotic transmission and occur, and automatically from then on, they begin to undergo what we call human-to-human transmission. There are 4 major genera. Most of them that affect humans are usually in the alpha and beta genera, but the ones that are of epidemic importance, that's the severe acute respiratory syndrome virus, severe acute respiratory syndrome coronavirus that causes SARS, MERS, the Middle East Respiratory Syndrome related coronavirus, MERS, and then SARS-CoV-2 are all in the beta genus. Now, we've had epidemics from 2003 to 2019, which is the current one. We've had it occurring, and it seemed to be occurring at the shorter interval. Before, we used to have almost close to 5-6 years or more, but now we just finished MERS 2018, and by 2019, another one has started. So that means we have to now begin to consider where more outbreaks of coronaviruses, possibly different from the ones we know today, will be occurring. Now, the virus itself, it's the general description of coronaviruses is what we call the corona, and that is this crown-like, which is made up of the spikes, the glycoprotein spikes that come out, that you see projecting out of the envelope. The key thing to remember is that the genome contains 10 open reading frames, and the open reading frame 1, which has sections A and B, is of critical importance, particularly for diagnosis, because that is where you have, so not only that is it 2/3 of the genome, it's also where you have some conserved areas, like what codes for the nucleoprotein, that's the N gene, and the gene that also codes for the RNA-dependent RNA polymerase, because these are targets when we are doing diagnostic testing. Now, for transmission, we've realized that a lot of the transmission has been by asymptomatic patients. Originally, it was from symptomatic people to symptomatic to others, but now about 20% of people who are 20% of those infected are asymptomatic. And because this was asymptomatic, either they don't take particular care, they don't wear the face mask, they don't do social distancing, they still go to work, they still interact with others, and others also interact with them freely. So it was found that these people are possibly responsible for about 4/5 of the infections that arise during the community transmission. Now, this virus can be transmitted through respiratory droplets, we have mentioned before, and these droplets, for them to be of danger, is when you transfer them either directly from someone who is exhaling in front of you, when it has contact with the respiratory tract or the oral mucosa. Another way is if you transfer them from a surface where they have via your hands or another form might to the same orifices, either the eyes, the nose, or the mouth. Now, they tend to survive for varying periods. They survive even on inanimate surfaces. So they can survive, for example, on a table for 2 days to 10 days, depending on whose research work you see. Now, in a closed environment where you do not have circulation of air and all that, it's believed that the virus can remain viable for up to 7 days. So if you have a vehicle, for example, where somebody who is COVID-19 has been transported without adequate face protection, the virus that the person has left behind could be found within that place at least for 30 minutes. They will be in the air there for somebody who comes in. So this is why ventilation is important, and spacing is also important when you are talking about people traveling in closed spaces, airlines, buses, and whatnot. Also, we've also found that diarrheal stools, it has been found for up to 4 days. Already, stool has been found to be one of the infectious specimens. Infectious specimens have been found, number one, lower respiratory tract infection specimens, upper respiratory tract specimens, and then stool. It's only been found in 10 to 12% of blood from people who have been found to have COVID-19. So you have to be careful around sputum, around bronchoalveolar lavage, tracheal washouts, and all that. And of course, we've mentioned that in presentations that these are some of the dangerous things when you create aerosols, particularly when you are doing suctioning and all that. This is why it's a dangerous procedure. Now, so far, this was just mentioning, this was more than a week ago. And of course, the new figures are as of June 3rd, which was yesterday, that we had close to 6.3 million and we had 380,000 deaths and counting. Nigeria has had over 10,000 as of today, 11,000 cases with about less than 300 deaths about for now. Now, what are the control measures we are advised to use? We are asked to do social distancing, and this includes the healthcare sector. It means between patients, whether it's where they sit, their bed, their couch, at least have 1 meter between. And then even when you are finding out what a patient has at an A&E or at a normal clinic, these are not people on an emergency basis, you still have to make sure there's a distance between patients and between the healthcare worker and the patient. Another thing has to do with the hand hygiene, washing your hands with soap and water, your patients washing their hands with soap and water, and also providing them, if we don't have this, with alcohol-based hand rubs. Wearing the right PPE, and this PPE is not until you are gowned fully. The first line of PPE important is to have the face mask, not only on yourself, but for patients who come into your healthcare facilities. And then, of course, making sure we do environmental cleaning and disinfection. Luckily, the everyday agents we have, which are based on alcohol-based agents and our hydrogen peroxide and sodium hydrochloride, these are actually effective in terms of inactivating the virus. And these are things we should use to ensure that our environments are kept free of the virus. Another thing we must remember is testing, which has been brought is that we need to be able to test people to ascertain whether they are actually having COVID-19 or whether they're not having COVID-19. And then the basic methodologies are using the laboratory and using the radiology in form of CT scan. Now, the ability of its health system is been said to diagnose the COVID-19 early will enable you to be able to handle every other case that comes in. Because if you are not sure who has COVID-19 or not, you might be taking unnecessarily preventive measures and tying down your health system. Or you may fail to provide the right service to someone who needs it because you're avoiding the issue of COVID-19. But if you're able to tell what the patient has, and then you can apply the appropriate method to approach the patient. Diagnosing it clinically is available, but it's now challenging because some of the information we used to use, finding out if that patient had traveled, have you had contact with somebody who is coughing, and some of those things are not readily available. However, we should not let go of finding out patients who have fever, who have cough, because these ones are symptomatic. So this makes it easy for such patients to be triaged as potential COVID-19 cases. But for asymptomatic patients in the background of community transmission, where there may be no history they have had with contact of somebody who traveled or somebody who is obviously ill and all that, the clinical diagnosis may not be so applicable in a lot of cases. Now we have the option of the radiological diagnosis. However, it has some limitations. Even though we found 86% sensitivity in some studies, however, there was a caveat. These were already patients that, based on the clinical assessment, they were already suspected of having COVID-19. And then the computed tomograph was done with the high-resolution computed tomograph, which is not readily available in every institution. In other words, those that are from 1.5 upwards are actually better. However, in those cases, we found that 56% of these patients had what we call bilateral parenchymal ground glass opacities. Even in some cases, it was in the periphery, but it's said to be pathognomonic for COVID-19. But then it's also been found not to be specific. There are a lot of other viral pneumonias can actually present with this. So there can be a challenge of not only that the CT scan is not available to every healthcare institution, but you may end up diagnosing patients with COVID-19 when what they have is something else. Now, the WHO says the best way forward is laboratory testing, but then there are challenges, one of which is we need it to be accurate, we need it to be convenient, we need it to be rapid, because if it's going to take almost 2 weeks to get a result, what do you then do with the patient in the interim? Since you know that is much, some patients, the incubation period is around 5 days. So are you going to wait 2 weeks for you to be able to do what you need to do? And what if it's an acute situation, like a patient who has trauma, and you need to know the approach to use for the patient? Now, laboratory testing itself, the kits that have come out, they have had to use some principles to assess if these kits will be relevant in testing, because we have to understand the dynamic response of every illness. In other words, what is the immunological response when an antibody is produced? What is the level of viremia at different points during the illness? And then does the result vary according to the age, gender, ethnicity of the patient? Is it readily available? Is it readily affordable? Are there mutations that will render these tests useless? Because if you go and buy a panel and then you are told that in some cases, those who have this mutation, it may not detect them, then of course that means there are people who you'll be labeling false negative. Now, the laboratory testing, what are the specimens we are expected to go for? Respiratory tract specimens, because this is a respiratory loving virus, so to speak. It has a predilection for the respiratory tract. This is its portal of entry, and this is where you have replication occurring in the initial phases. So lower respiratory tract, which is closer to where the nodus of infection is, bronchoalveolar lavage, sputum, aspirate, these are the best specimens. However, they carry a high level of risk in terms of biosafety. Now, we found that upper respiratory tract specimens can give you up to 80 to 90% sensitivity. So the fact that they are safer and easier to collect, we prefer to go for nasopharyngeal and oropharyngeal. However, the nasopharyngeal is much more convenient and also safer, because when you ask somebody to open the mouth and you insert a swab, you can stimulate the cough reflex and all that. So the nasopharyngeal is actually safer. But in a situation where it's not very easy, we are told collect in 2 nasopharyngeal swabs or 1 nasopharyngeal swab and 1 oropharyngeal swabs. Other specimens we are looking at in the long run include blood, which will be used for antibody antigen testing, Dr. Lawa will talk about, and then urine and all that. But we found that it's not possible, the virus so far is not readily found in urine. So it leaves us with the issue of respiratory tract specimens. Now, following COVID-19 testing, there's an algorithm we are looking at. If you want to do direct, go for molecular testing, which gives you 2 options, the reverse transcriptase PCR type and the isothermal type. And then viral culture, which is normally done by higher labs, but is the one that actually gives us information on mutation and changes in the gene. But for use in diagnosis, it will be based on nucleic acid amplification testing. And for now, the WHO has advocated the use of the reverse transcriptase PCR. The indirect methodologies are more numerous, are said to be cheaper and more rapid. Dr. Lawa will talk about them based on serology, based on antigen testing. Now, the nucleic acid testing, the reverse transcriptase PCR, and then the type that gives us quantitative, we call it the real-time reverse transcriptase transcription polymerase chain reaction. This gives us, what it does is that using immunofluorescence, it's able to follow the amplification process of the virus and be able to, in the shortest possible time, give us an idea of the quantity of the virus present in the specimen. And it has an interpretative algorithm. Usually, remember, there are 2 specimens you are asked to collect from the patient. You are actually aiming for 2 targets, which we'll mention later. If both targets are found in the same specimen, then that means the positive one. If you find 1 target in the 2 separate specimens, each has 1 target positive, we regard it as the same, as positive. If there are 2 specimens, for example, a nasopharyngeal swab and an oropharyngeal swab, and each of them has 1 of the targets positive, we also regard it as positive. However, it's also prone to the fact that some patients have been found not to elaborate enough quantities of the virus in their respiratory tracts, that when you collect a nasopharyngeal swab, it will be falsely negative. And this can range between 3 to 7 days. That's the average, with an average of 5 days. And then patients will also elaborate it, even when they have been clinically proven to have recovered from the illness, they could still be found to be positive for some days after. Now, the molecular methods, as we mentioned earlier, usually target the genome. And we said one of the areas we look at the genome is the open reading frame 1, which has A and B. And one of the targets is the RNA-dependent RNA polymerase. However, the reverse transcripted PCR, RT-PCR, is not 100% sensitive or specific. Depending on the kit you use, it can range between 71% to 98%, and the specificity can be between 95% to 100%. This is also highly dependent on the methodology, the method in which the sample is collected, the method in which it is handled, stored, and other things. Now, there are some disadvantages. It tends to be costly because it needs a thermocycler, and even the fastest methodologies for now with PCR, none of them has come below 2 hours on the average. On the average, some of them take 8 hours. So when they pull samples, when they need to pull samples, sometimes it can take more than a day or so for the result to come through. Also, it's technically demanding. It needs somebody who understands the methodology and the technicalities to be able to use it. And in some resource poor environments, they do not have people who can easily be trained and who can be trained, and then this is handed over to them to use for diagnosis. That means we may be looking at alternative methods of diagnosis to molecular, one of which is using isothermal techniques. These techniques, because they are based on a different methodology, they actually amplify with a polymerase that does not need the constant temperature change you have with the thermocycler. So that means you can amplify RNA at a constant temperature, which eliminates the need of a thermocycler, which is one of the most costly expenditure with the RT-PCR. They also have more targets that you can actually go for, and that makes them, where you can actually give a higher level of sensitivity in some cases than what you can get with the RT-PCR. Also, because the steps are not, where you have cycles of heating and cooling, it can be faster. Some of the instruments brought on board actually giving results in less than 30 minutes. We have had results ready in 15 minutes or so. So with all this, it actually means it gives us a credible alternative to the RT-PCR. So one of the things looking along the line is for the WHO to encourage manufacturers to develop more effort into developing point of care testing using the using the isothermal techniques. One of the most popular is the reverse transcriptase loop-mediated isothermal amplification, which is the RT-LAMP. We're already getting very good results with this in terms of the African trypanosomiasis, in terms of tuberculosis, looking for multi-drug resistant tuberculosis and all that. So it's something that is being brought on board. 1 or 2 companies have actually brought up machines that are actually being used to diagnose COVID-19 using the RT-LAMP methodology. This is a comparison just telling you the advantage of RT-LAMP versus the reverse transcriptase PCR. However, molecular testing has some limitations. One of which is as the specimen is, the result you get is subject to the quality of your specimen. So if you have poor collection, if you have specimen contamination, poor storage methodology, storage conditions, these are things that can affect your result in the long run. Additionally, remember that there's a period where if you test the patient, because they has a lower limit of detection, some of them, if the detection limit may be less than 40 copies per mil, you may have the thing by microliter to tell you that it's not there when it's actually there. That's a false negative. So what would be the consequence if you have a primary care physician who has to use this result? One of which is that you end up treating patients who actually have COVID-19 as non-COVID-19, and that is the risk of spreading the infection down the line. And then, of course, there's the issue of the delay for the patients while they are waiting for results, if you are busy delaying the treatment for the patient because of this. So what is the possibility for the primary health physician or the surgeon or the internal physician who is seeing a patient and he needs to make a decision as to how to handle this patient, particularly when the patient is asymptomatic? It means you have to look at a combination of not just one methodology that would fit the mold. In some patients, you may look at if you have the facility of a patient who you think it doesn't look like COVID-19, so to speak, but he has something respiratory, or you have to even send him for a CT scan already because this patient maybe has a trauma or something. It's good that you do a CT scan of the chest because this will help you because if you have an index of suspicion, then with the CT scan giving you those results, that would be more or less confirmatory. Why you still send that patient for a reverse transcriptase PCR with, for example, in Nigeria, the NCDC, and you're waiting the result? Another thing would be in some patients, maybe we have to look at how to bring in serological assays, because these are faster. This can be brought closer to where the point of care. And of course, they have their own limitations. Dr. Lawa will talk about them, but we also have to say, in what situations do we need to bring these technologies on board? And then the WHO, of course, which is the kind of a pan body for healthcare issues, we begin to look beyond the RT-PCR with its limitations. We have to begin to look at other technologies like the RT lab, so that we can have alternatives available as we begin to open up our healthcare system with the epidemic, with the pandemic on the not on the fall in areas outside Africa and South America. While the epicenter moves, these areas are beginning to ramp up, and eventually we know we'll come back to where the pandemic will be over in our own area, but we know it will still be burning at a low level. Then, what do we have as technologies that can be brought closer so that we can get results very fast, just as a patient is waiting in the waiting room? That will at least now tell us which direction to move. So we need to see how we can bring in these technologies on board. So having said that, the physicians, the surgeons, the anesthesiologists must not forget that for every patient, treat as a COVID-19 case, and that means contact precautions. Have your face mask, do your hand washing in between, physical spacing, and then have the spacing between the patients.
No, Dr. Prince has finished his presentation.
Oh, okay. I was
Yes.
cut off.
So
Okay.
we want you to continue the next leg of the presentation.
Yeah, I'll be with you now. All right. I think we've talked much about the molecular. So I'll be taking it from the antigen-based diagnostic, then serology, and then the COVID-19 surgeries and other medical decisions. We'll talk about that during the interactive session. So please just stay with us. I'll try and rush this through. Okay, this is a slide I got from Professor Rosanna Peeling of one of our presentations. And starting this discourse, we'd like to understand the 3 A's. The 3 A's when you talk of diagnosis tests. And these 3 A's talks about accuracy, accessibility, and affordability. So like Dr. Princefield had said there are two broad types, the direct, which is the molecular, and the indirect, which can be the antigen or the serology-based tests. The targets are what makes them different. So in molecular, your target is RNA. In antigen-based, there's the RNA that are part of the components of the virus. You try to detect those proteins. So these are proteins that are produced by the virus. We'll talk about these proteins shortly. Then the antibodies talk about, in any viral infection, the body mounts some sort of response, by producing what we call antibodies, okay? We'll talk about those ones too. So when you would target the production of antibodies, the test is called serology tests. And from this slide, you can see that the sensitivity and specificity is very good for molecular, even though some of those limitations that Dr. Prince talked about makes it an issue, means it could be very expensive. Now people are just walking into, to access this because it's being funded by government and all that. But it's also very sensitive. In between, we have the protein, the antigen-based tests, which the target is protein. It's actually relatively in the midway type of it. But the ones that is least expensive is the antibody test that can be of wide use. It has a good accessibility, as you can see, and it can be sensitive to and can be specific. But the only drawback is that it takes some time for us to to produce this antibody. So you can say optimal detection time post onset of symptoms is between day 7 and 40 for you're going to use antibody-based tests. It's also good to put. I hope we can see this this slide. I hope it's clear enough. We can see. I also saw this from Professor Rosanna Peeling, and you can see viral infection generally, the relation between viral infection and the immune response dynamics. So this is what we're talking about. Okay, there is the onset of symptoms can vary in many viral infections between between 2 days and 14 days, just like we are seeing with COVID. Some people develop symptoms earlier, some later. However, once symptoms are, if you look at the concentration of the RNA. It rises sharply at the beginning and starts to tail down, and the antigen too rises sharply. That what simply means is that we can, between day 0 and day 7 from onset of symptoms, where these tests can be picked. But by the time we are doing molecular tests between day 7 and day 14, we can say maybe it can be what they call it can reduce to like 50% the chance of getting a positive test in an infected patient. There's a difference between a test being positive and actually the person being infected. Okay, so the person can be infected and the test will still turn negative, maybe because at that time the RNA, the antigen have gone down. But if you look at the antibodies now, antibodies starts to rise. Antibodies we'll talk more about later. IgM and IgG, they all have specific. These are antibodies that are produced. IgM is the first one that is produced for new infections, brand new infections, while IgG takes over later. These are produced by plasma cells. These are transformed B cells. But you can see from this slide, one takeaway is that a four-fold rise in antibody titer between acute and convalescent cellular can give you a definite diagnosis of a viral infection. Yeah, we'll talk more about this. Just let us follow through. All right, so Dr. Christian has talked about the right sample, transporting the right way, and all that. But we need to look at some of these because he was mentioning so many percentages. I just brought this out. You can see that bronchoalveolar lavage has a 93% chance of okay. All right, so if it's just nasal swabs, you have 60% while pharyngeal swabs. I think we are talking more about this. We do oropharyngeal swab taking here and all that. But this is what's interesting. A paper by Go et al. Showed that molecular testing, this is nucleic acid, identified only 50% of infected persons. And I think bad news everywhere. I mean, the so-called almighty molecular testing is only just picking 50% of infected persons. That's serious. And the paper concluded that humoral response to SARS-CoV-2 can be an aid to diagnosis of COVID-19, including subclinical cases. I think we need to look at this. There are other, okay, so now let's talk about, I'm the chemical man here. So the proteins that are targeted to coronaviruses, there are 4 main proteins: the spike protein, the M protein, the E protein, and the N protein. These okay, am I back?
Yes, you are.
Okay, so there are 4 proteins, and it's like these proteins are expressed by coronaviruses. But SARS-CoV-2, there are, spike, it's like having, let me explain it now. We know all cars have 4 tires. They have headlights, they have boot and all that. But then cars can be specific in that there's Toyota, there's Mercedes-Benz, there's Honda and all that. So these proteins have those differences. So the spike protein for coronavirus is a bit slightly different from of COVID-19. It's a bit slightly different from the other coronaviruses. So tests antigen tests and antibody tests can be developed against to target these proteins. All right. So, in fact, talking about serology, most of the antibody test kits that we're having are targeting the spike and the N proteins. In fact, more of the N proteins, because the N proteins are immunodominant, meaning that you can always find them. So they are the targets of these serological assays. All right, getting too technical, I just want to. So these are antibodies, the IgG, IgD, IgE, IgM, and IgA. Others are beyond the scope of this particular seminar, but mainly IgM is the one that is produced when you have when you have an infection that's the first time it's happening. Then later bodies are producing the IgG. Okay, so the IgG, I'll show you some graphs. I'll show you some graphs for some subscribe. But in general, antibody response to SARS-CoV-2 infection can be host dependent. I can take some time. Okay. From 2, like you can see, it could start from between what do you call it, incubation period. You saw that graph. Okay. Majority, however, seroconvert between 7 and 11 days post exposure to the virus. Now let us be very clear. Post exposure is not the same thing as post symptom onset, okay? Exposure means once you came in contact with the virus before the infection actually develops. But you can see some can actually develop antibodies sooner. I would like to draw your attention to this abstract because this is from I think this is from a surgical body in the US, Journal of Arthroplasty. And when they were having issues, especially when this COVID pandemic started, some of the surgeries, they were having issues delaying surgeries, they didn't know what to do. And they looked at understanding antibody testing. And let me just quickly read the abstract. They said the orthopedic community has seen that the COVID-19 pandemic decimates elective surgical volumes in most geographies, meaning more surgeries are being rejected. Patients and essential workers, such as healthcare providers, remain rightfully concerned about how to appropriately begin to return to work and community activity in a safe and responsible manner. Many believe that testing for the presence of antibodies on a widespread scale could help drive evidence-based decision-making, both on an individual or societal scale. Much information and equal amount of misinformation has been produced on antibody testing. Education about the role of the science of such testing is critically important for programs to be effectively managed. That's what they said. The other excerpts from the paper, the same paper promoting the same antibody testing. Well, you see what I want to read here is the second paragraph here, which says testing also may provide peace of mind to surgeons. It's not easy, who are unsure if they have been exposed to the virus. Because if they've ever developed immunity to the virus, knowing these facts may actually educate decisions about the needs for PPE and one's willingness to work with COVID-19 positive patients in the elective sector. So what I'm just saying is that if you do an antibody test and you find out that maybe you were infected, you didn't even know, the silent infection, which I don't know, is that you don't get an infection, you pray for a silent one that doesn't take you anywhere. You may actually now start beginning you can start, you can have more confidence to at least to work with these COVID-19 patients. We know that immunity doesn't mean that you cannot be reinfected, but even if it comes, it will be a very mild disease and you quickly recover from it. That was immunity basically. But we don't know. There's still a lot of studies going on regarding how long can immunity to COVID-19 last. Many papers are still being written on that issue. So let me quickly say that regarding antibody tests, at least these have been documented. They can be used to facilitate contact tracing, serological surveillance. They can use the identification of those who have already had the virus and those may be immune. It's also possible to look at those. Serology testing may also be useful in identifying individuals who will be a source of therapeutic or prophylactic neutralizing antibodies. You see, if you know some people that have recovered from the virus, their blood is being collected and the plasma is produced with the hope that they can use this plasma to actually treat people that are very, very sick with the disease. This has also been employed as part of the therapeutic trial. Antibody tests can also facilitate research studies to determine the sensitivity of PCR. Yeah, this almighty molecular test, you can actually use the antibody test. That's, of course, the infection has taken place now, to find out whether really you can use to retrospectively determine the true scope of the pandemic. And I think, the last point here is that in those that are negative, that's molecular tests, RNA negative individuals, that are presenting late, and maybe by that time the RNA titer is so low that it didn't actually pick any titer. Antibody tests could be useful in diagnosing those ones. But let's look at what WHO, what was the advice that the antibody test? Let's look at advice and some other bodies. WHO was very clear. Based on the current data, WHO does not recommend the use of antibody detecting rapid tests for patient care, but encourages the continuation of work to establish their usefulness in disease surveillance and epidemiologic research. If you look at this face value, you may tend to just want to pick it, but let's look at it critically. The keywords here are what? Patient care. So, in order not to falsely isolate people, and because of the fact that the margin of error, can also, it takes some time for antibodies to develop, you don't want to use them to actually isolate and say you want to treat a patient. For NCT is using molecular tests, that is the way to go. But if you also look here, but encourages the continuation of work to establish a difference in disease surveillance. Disease surveillance and that keyword. Look at it, okay, you do look at those that have already been exposed to the virus or those that have developed some immunity and all that. Moving on, I like to quote the ASCP, who just summarize this. ASCP is the American Society for Clinical Pathologists. They are also a very recognized body in the US. And their takeaway from their from their paper, is that at a time where diagnosis speed is of the essence, testing laboratories are the limits of their capacity and reagents are in short supply, especially in Africa, in Nigeria here. These point of care tests detecting SARS-CoV-2, that's COVID-19 antibodies, seem like the perfect solution. And test makers have responded by adapting their previous pathogen detection assays to COVID-19. But as the WHO reminded us, there is also a major risk of relying on these tests unless and until they are proven accurate enough for use in clinical decision making. So what are they saying? We need to look at the accuracy of some of these tests. But let's quickly bring some where they even use antibody testers for triad. In Peru, currently, this is a dated this thing, but their website, this is I got from their website. I'm sure by today is June 4. You have more current details here. So where they employ antibody tests, you can see that they test molecular tests at this particular, as May 10, more than 500,000 have been tested. Molecular tests they did was 79, more than 79,000, and the rapid test is more than 400,000. And you can even see that they pick some rapid. So they did some positive cases with rapid tests, which of course they now went to ahead to confirm with the molecular test. Okay, so in Senegal too, they've used it and all that. Now, this is important. FIND is a global NGO, and I like them because they've looked at the fact that the COVID-19 has brought up a situation where a lot of manufacturers, in fact, they are bombarding the market with a lot of testing kits, whether molecular kits, antigen-based kits, or antibody-based kits. So what they are doing is like they're a leveler. They are like a third party. They are currently a third party validation of some of these test kits. So what the manufacturers are supposed to do is to provide them. So they are like doing the function. They know they just want to safeguard the health of the population so that people using them can learn them. So these kit manufacturers submit their kits to this FIND, who they've already defined their criteria for their validation, and you can see everything is open. It's not shrouded in secrecy, and you can see, and they will list those that have been validated in their website. So FIND is doing a lot of good things, a lot in that regard. For countries that don't have much resources, FDA is a big body in the US, and they will make sure that they validate all the tests in use in the US. Europe will have their own body. But what it is, European is helping to just try to put everybody on the same pedestal, like a leveler, so to make sure that you can compare the performance characteristics, the accuracy of test kits, across the same benchmark. And when you talk about evaluation, basically, we're talking about looking at the analytical sensitivity, the analytical specificity, reproducibility. These are terms I may be able to elaborate more upon during the Q&A session because of time. So we also look at the clinical sensitivity, that how many people was able to, that are positive are really positive. How many people that are negative, were they really negative compared to a particular gold standard like PCR? Okay, then you talk about positive predictive value, negative predictive value, and all that. Then, of course, part of evaluation is risk management analysis. You also want to look at the cost-benefit ratio. Some of these things, they are more expensive than they're actually doing good. Then, what is the cost-benefit ratio? Is it helping controlling the pandemic or all that? Performance tests for analysis. For test, performance analysis of tests follow this. So evaluation of already is what the manufacturers do to find out, and they have to publish it in their package inside. So you see the evaluation, they report what I just listed in the other slide as an evaluation, they publish it. So validation is what a third party body does, like the FDA, to find out that if, for instance, if you say the unit of measurement for a particular test is 54, for instance, 24 grams, you want to find out a third party wants to find out whether that test kit is actually measuring that 54 grams. So that's validation. I cannot really elaborate on that now because of the scope. But verification is actually something you can do in your hospital, in your lab, or wherever you are, to find out whether what the manufacturer is screaming is test kits. So we test like maybe 100 individuals and see whether those 100 individuals have been confirmed positive, or 50 individuals have been confirmed negative, whether they're really negative or not. And you have to publish it for record keeping. So this is like the way you go about, and these are things that pathologists do to ensure that before you start using a test, before they recommend a test to you, before they be able to report on a test, they ensure that the evaluation, the validation, and the verification all check out. So we can say that, just to summarize, antibody-based test kits are correct. They found some use in rapid triage of subset cases like they are doing in Senegal or Peru. It can be used to test cases of contacts or suspected cases. Now, let us be clear. Cases are defined by molecular tests. So You get a molecular test that is positive. This person is a case, and you isolate or you do another. You know, but antibody testing is like a surveillance tool. So it's also used in situational analysis and surveillance, which we think may be brought to bear in some of the issues we are having in our, in our health sectors that are unable to access this molecular test. So in the market, we actually look at a particular test kit, and okay, if you can see those graphs, I was talking about IgM being the first to rise, then followed by IgG. And then depending on the time you pick them, so you could have some false negatives as false positives. And anyway, this one just shows you how to use some of these rapid test kits that can be employed without use of, you may not really need to a level 3, a high falutin lab, or where you have to wear a hazmat suit for this. So just blood sample you can use to pick some of these antibodies, okay? And we have the IgG. Of course, I won't go through this, but these are the things the manufacturers must publish as part of their evaluation and their packaging side. But what is important to us as pathologists, look at some of the performance characteristics. And if you look closely at this as the first table, you find out that, okay, the 2 tests are involved here. In this particular case, it does IgM and IgG. And you can see in comparison, they compare the PCR tests at the gold standard. So they are comparing their kits. And out of 44 that were actually positive with the PCR, they picked the kits picked 42, you understand me, and 2 false negatives, okay, giving a sensitivity of 95.5%. Out of the 102 that tested negative with PCR, the kit actually picked all of them, okay, that is, I'll give you 100% specificity. And so overall agreement between sensitivity and specificity is now drops to 98.6%, which is generally okay. Okay, sorry. Then for the IgG, and what IgM, okay, we'll talk about that later. For the IgG, it's a performance characteristics, 54 were positive with PCR, and it picked all the 54 that were positive. And 102 were negative with PCR, or it picked 100 out of it, and 2 were falsely negative. So, of course, no test is perfect. So that's how to interpret some of this. But you see, this is at face value. As a pathologist, you want to look at some other baselines. That what is the days, maybe say 5 days post symptoms, 10 days of post symptoms, 20 days of post symptoms, and then you look at the sensitivity, the specificity, and other things you look at, which are actually beyond the scope. Another thing you also want to look at is that, okay, these test kits, do they have anybody validating them? And so you look at a body like, okay, this American screening is being validated. I mean, it has been listed in the FDA. And of course, next thing you ask whether they have their validation certificate, meaning that the FDA has actually approved them. So that's some of the things you check, But it's important for us to look at this slide. For antibody-based kits, which we think may be useful, if you have IgM that is negative when you do a test, negative IgM, negative IgG, and no symptoms, most likely this patient has not really come across this COVID-19, and you may not need to go ahead and do a molecular test, and you may just go ahead and do your surgery. Of course, you still do your PPE, but at least you have some level of idea that maybe this person is responsible. If you have IgM negative and IgG negative with symptoms, that means this test kit, may not have picked it, and you must go and do your molecular test to ensure that you are not just going ahead, because you have symptoms here. You may have IgM positive and IgG positive. This is a rare signal. That means that this patient the infection just started and this patient is infective. But then to treat and isolate, you need confirmation with molecular test. But at least for you can, for those that need to do procedures on the aerosolizing and all that, you may want to temporize while you wait for your confirmation test. So this can help. IgM positive and IgG negative. This means still an active case. IgM means a new infection, so IgG has not even developed yet. So it's also a rare signal, but you still need that molecular test for confirmation if you have to fall into the NCD criteria for isolation this patient and tracing their contacts. But then, in our rural settings, this may also be useful to triage and survey. You can have IgM negative and IgG positive. Of course, this is one some people are talking about, that you may have had a silent infection and the thing just went away quietly, and you develop some immunity. So this can be further upload, and you may still want to go ahead and do molecular tests to check some of this because and all that. All right. So the hierarchy of evidence molecular test is at the peak. That is it. But molecular tests will have their own. It's not there's A, B, and Dr. Puri put a lot of expanded and all that. So we have those that have been deployed for rapid testing too, which of course takes a quick. I mean, the results comes out quicker. But of course, you can't. There are no shortcuts to success. So molecular tests takes some time, and one can now understand why it takes some days for molecular tests to come out. Antigen-based tests, yes. I think some 2 weeks ago, about 2 companies or a company was approved in the US. But for that, in the US, they've not really got into our part of the market. Antibody-based tests are out there. The good, the bad, and the ugly. We don't know whether some of the ones rejected were the UK or the Spain, where they had their pandemic, has found its way to Africa. We can't really say. But what is important is I mean, that's what we do as pathologists. We try to look at the accuracy of some of these the performance characteristics to see whether we can advise our colleagues regarding what to do. COVID-19 is a race at this time, and I think hospitals cannot close up, will remain open, and we are in for it for the long run, and we need all arms on deck, every facility. There's a hospital from one of our resource persons yesterday in the US who said that these molecular tests, they do it in their hospital standard for patients that are going to surgeries, for patients that are going to labor ward, and for people that are going to have procedures like laparoscopy and all that standard. They don't have to start calling NCDC and we take 2 weeks and all that. We wish we can have that kind of resource here too, but we know that we know that with will and all that that may be done in the future, and they're looking at that. But antibody-based testing can also do something. The FDA is a very respected body, and everybody has FDA, of America, because they control use of medications, they control tests, they must validate them, and it's a big body, and whatever they say, a lot of people follow, and all around the world. That's the American FDA. And we wonder in Nigeria, who is our FDA? Is it the PTF, or the Federal Ministry of Health, or the Medical Laboratory Science Council, or NCDC, or NAFDAC? There seems to be, because, the MLSN some weeks ago came out with a press conference in which they said, they validated some kits, and they basically just condemned, or rather the results came out and they said the defeats were, that nobody should use them, and they kept, they're making some threats. Well, Medical Laboratory Science Council regulates medical laboratory science, and for we pathologists, we're not under their purview. Validation, we won't believe that. It's very unusual for, or rather, it's inappropriate for NUC to set up a university. You're a regulator, and at the same time you want to be an operator. So we think there's something wrong here. That's because then scientific, when you find evaluations are not subject of press conferences. These are things you put on your website, and everybody sees what you're doing. We note the benchmarks you used. We know anyway. I don't want to go so much into this. We can talk about this during the other sessions. My key messages. Okay, it's coming from under. Okay, so the COVID-19 pandemic has presented novel challenges to the healthcare system. Not even the system, with everybody. People are finding it difficult to wear face masks and all that, and even schools are still locked down. Yes, it's very challenging. People are still trying to find out how to come back to work. Many companies are looking at ways to see how they can keep safe at the workplace everywhere. Molecular tests are the gold standard for the diagnosis of COVID-19. That is what you must do, where you can isolate a patient, and you can start treatment of a patient. And all that. However, antibody tests too may be useful. Antigen tests too are there, but they are not widespread yet, and the research is going on. But antibody tests are there. They may be important in detecting infections with few or no symptoms, like we highlighted. Past infections, and they can also be used for immunosurveillance, but you need specialists that will look at them for you and try to appropriately guide you. Thank you very much. I want to apologize for all the glitches, the switching between internet. So I hope I'm stopping my screen.
Thank you very much, Dr. Lawal. I also apologize for the glitches, but I'm sure we're happy that everything went on smoothly towards the end. So we thank you very much, participants, for listening in. We are now going to ask if some of the questions have also been put in, some are being answered, but after our panelists talk, we'll be able to also address and take some live questions. At panelists, we have 3, of course, unfortunately, duty calls, and one of them is not yet available, but we're still hoping that he would join us. But we have Dr. Murayo Salawu, who is a consultant anesthesiologist at the National Trauma Center at National Hospital, Abuja. Dr. Salawu will give us perspective on this topic. And then we also have Dr. Nkolika Stella Wazuke, who is a consultant clinical microbiologist and head of the Infection Prevention and Control at the Federal Medical Center, Abuja. The third panelist that we're hoping will join us soon is Dr. Ayodeji Salman Yusuf, who is a consultant neurosurgeon at the National Hospital, Abuja. So we want to start with Dr. Salawu, please. Can you please just give us your views?
Can you hear me?
Yes, we can hear you.
Okay. Thank you very much for your presentation. As you can see, I'm also inside the theater with Dr. Yusuf. What I just want to say about the concerning anesthesia is that for emergency cases, we don't have any choice than to go in and do those patients. What we can do is that we should take the necessary precautions and make sure we are draped in our PPE. We know intubation is an aerosol generating procedure.
He's moving. Sorry, she has to attend to a patient. Sorry.
Please let the other panelists finish their talk. I'll talk last.
Yes. Okay, that's fine. Thank you. Yes, that is the importance of the profession. We're going to ask Dr. Wazuke to please start, and then hopefully we'll be able to get back to our colleagues in the theater.
Good afternoon, everyone. Please, can you hear me?
Yes, we can hear you.
Good afternoon, Ma. Thank you for the introduction. A very big thank you to Dr. Lawal and Dr. Princeville, my colleagues, for the wonderful presentation. I think they did justice to the topic. They were clear, precise, and loaded with the necessary information. You know, what I just want to say is that I think when it comes to diagnostic, when it comes to testing, every country should take into consideration their system, what they have in place. And then also the number of people in the country. Nigeria is a populous country, as we all know, with over 200 million people. And as we can see so far, we have gone nowhere in testing. And right now, we're in the community phase. So many cases are being missed out. Obviously, some people would have come in contact with this virus and been able to cope with it, and they even know. Some people are moving around, more so with the ease in lockdown, people are moving around with this virus, not knowing, and transmitting to other people. So it's so important that aside what we're doing now, the real-time PCR, I think personally, we should also have other systems in place, other means of testing that can bridge the gap, that the PCR has left, so that at least we'll be able to come up. As the surgeon said now, most times they have to go in, they don't know actually if this patient is a COVID-19 patient or not. And that is because we don't have point of care tests or serologic tests that are available that could give one a quick result that the doctors attending to these patients could use and know what to do. But be that as it may, we are being told that we should practice standard precautions. So you treat every patient as if that patient is a COVID-19 patient. But be that as it may, there is an urgent need for us to also put in place other testing systems that will help to diagnose, especially the symptomatic cases who are carriers who are moving around, and fill in the gaps, in the system, so that even if it's only using it as a surveillance tool, as Dr. Lawal said, at least those who have come in contact with the disease, you actually be able to define the disease burden, and then it will also help you to know how this disease is spreading through the population, and then it will even help in contact tracing. So there is no argument for me the need to also have additional testing mechanisms in place besides what we are doing right now in the country to be able to go, because for me, what we have done so far is not ideal. The number of people we have tested is not yet ideal. There is need to up the game and test more people and be able to isolate patients when necessary and their contacts, so as to reduce the spread of this disease. As Dr. Lawal said, COVID-19 is really a race against time. Thank you.
Thank you very much, Dr. Wazuki. We're going to look at some of the questions while we wait for Dr. Salawu to come back. And even though some have been answered, I think it's necessary that we have them addressed so that more people would be able to benefit. So between Dr. Princewill and Dr. Salawu, there was a question asking if any hospital in Nigeria can actually do the COVID-19 test. I believe people are looking at the possibility of walking into a hospital, probably seeing a doctor, and requesting for.
At the moment, one of the ways they are looking at rolling out the testing beyond the few limited places is using some of the information we already have. One of which is, there's a platform which is using the Cepheid machines we have in place for GeneXpert. If we bring these platforms in, that would increase our testing at more than 100 to 200. Some estimate we could bring in up to 400 machines on board, because it's already being used for TB. So if we have a lot of centers that already have these machines, the kits are available when they come in country and they are validated. That's a way of expanding testing. However, the platforms that are being used, most of them are like the Cobas platform from Roche, the platforms from Abbott. These systems are not available in most of the teaching hospitals, except, for example, some hospitals already had some of these platforms for doing HIV testing. So these are the centers that were initially looked at for the expansion. So we don't have up to, I think board now that you can actually carry out this testing. So this is a very limited number of centers. Now, the hospitals carrying this out are not carrying them out just for their patients. They're actually reference centers for samples. For example, a center in Kano will be collecting specimens as far off as Sokoto, Katsina, Jigawa, and then Kano itself. So it won't just be for AKTH alone. So the long-term plan towards between now and September is to roll out more centers. But one of the challenges is using the current RT-PCR methodology. A lot of centers cannot afford to buy them, and they're not looking at buying those machines. So the option they're looking at is using the GeneXpert machines. But these have a limited number of tests they can run in a day. As for the private hospitals, I am not aware of any private hospital that has brought in country a molecular diagnostic test per se because of COVID-19. So those are some of the limitations we have.
Okay. So thank you. I hope that addresses that question, that, well, for now, we have to do the testing through the available channels. I also want to find out, although I know it's been addressed, but probably the person didn't get it from the presentation, but do we have the RDT tests kits available in Abuja, was asked, but I think more like probably want to say, do we have the RDT kits available in Nigeria?
All right, I think this one is for me, right?
Yes, Dr.
Yeah, so the answer is yes. and no. Yes, because somebody may just approach you on the street and be telling you, I mean, about this and all that. The kits, they and all that. No, because, well, some of our colleagues are beginning to carry out some validation tests on some of the kits they think that what they want to look at it. And when they are done with that validation and we see the information and we analyze it, then I, as a chemical pathologist, can say, yes, I can recommend this particular test kit, and I can even offer the test myself. So we need to be cautious. Like antibody test kit, like I said, lots of kits were rejected by the UK, and I don't know whether it's antibody and Spain, but we also know that they may find themselves to Africa. Africa, we seem not to have a way to safeguard our, what do you call it, the products entering Nigeria. It ain't just getting anyhow, whether you know. So that's my answer. For now, I've seen some out there in the market, but I'm waiting to get some of this information, and I mean, I will now appropriately advise colleagues, those that may be interested. But it's I mean, they're being used in some jurisdictions, and like I said, if you understand the no love lost between the medical laboratory scientists and you may understand why somebody needs to go to a press conference and starts talking about evaluation they did and reading riot acts for people not to. That's not the way to go scientifically. If you actually did the validation, you bring it to you bring out your methods, what you did. This we don't. Anyway, don't let me talk more on that. What I'm saying is that we also have opinion regarding the kits that we can recommend. But I also mentioned, if you remember, I said there's a global NGO. Just Google it. Find COVID-19. You'll see the list of companies that have submitted their molecular tests, antigen-based tests all over the world, whether in China, whether in the Netherlands, in the US, UK. They are submitting to them. They've defined their criteria that they want you to validate. And if I'm sourcing such an antibody test from, so I'm on a good pedestal to say, yes, I want to go ahead and utilize some of this. Then I'll now use my professional judgment, do my own validation and verification, then offer the service to those that may need it, because we know that a lot of our colleagues don't like to mix what they call the blood and pipette. They stay up there. Well, so that's the answer.
Thank you, Dr. Lawal. Actually, there is a question here from Habib Bagbola, and I think it's probably, okay, he's tried to break it down. The question is also just to ask that for patients who have recovered from COVID-19, would the serology tests be appropriate for pre-op screening? What he really wants to know is if the serology testing can differentiate those who have recovered from COVID-19 and those who are newly diagnosed. So that has to do with IgG, IgM. Maybe he needs to have a bit of clarity on that.
Okay. Thank you very much. Okay, I wish I could know the background of the, let's say, answer the question, but let me just put it this way.
Yeah, well, maybe
doesn't matter.
He can let us have an idea of his background.
We need to be cautious with antibody-based tests. So you do an antibody-based test that is IgG, that has both IgG and IgM, and they are both negative. That is not telling you that it's 100% negative, because it depends on when you are catching the patient. Do you understand? But I think his own question is from the fact that whether somebody has been previously exposed, or let me get it again. Okay. Can you repeat the question? I want to get it.
Yes. Okay. For a patient who has recovered from COVID-19,
okay,
would the serology test be appropriate for pre-op testing? Which means that test actually tell you that this person has recovered, or this person is still in the process, has not recovered, still has an active infection.
Okay, so
well,
I wish we had the resources in this country. If not, molecular test will have been what I would have recommended for this particular scenario. Molecular test first. And of course, if the molecular test is positive, then you can take your decision on whether you want to temporize on the surgery or whatever you want, or you want to double PPE or whatever you want to go about it. Okay? But the molecular test too can turn out negative, right? It may turn out negative, maybe because at that particular time, the concentration of the virus, the yield has really reduced. And if the person has produced antibodies, he has had previous infection. So most likely he will be IgG positive. Okay? Only IgG being positive doesn't mean that person has an active infection. So it may just show that he has developed antibody. Unlike HIV, whereby it's a chronic condition, this is COVID-19. So the person may have recovered and IgG is positive. The discourse now is to find out that can we estimate what you call neutralizing antibodies? This IgG that is positive, which part of it is, what is percentage that is neutralizing? Neutralizing means that it offers a protective immunity against reinfection. So the kit cannot tell you whether they are neutralizing, but you can only guess that this person has been previously exposed. And by the time you do your, at least in our setup here, you do your symptomatology, you check the risk and all that. You can hazard a guess as to the decision you want to take. I don't know if this has addressed the question.
Well, yeah,
Thank you, Dr. Lawal. If I may, ma.
Dr. Prince will also want to give.
Let me word in a little bit. Thank you for the question from Agola. Well, if you look at the patient's results, Dr. Lawal brought out a table, and what you are seeing is IgG. Usually, why the WHO recommended that we need to not just dismiss the issue of serology, why they want more work to be done on serology so that we can have some of these results. We want to know what is the cutoff of IgM that tells you that IgM is on the wane. Because when you see the IgM, that's the acute phase. So we want to know, like we do with hepatitis B, what is the level of IgM that we'll see that will tell us most likely if the IgM is at this level and the IgG is at this level, this is a patient who is in the recovery phase. And if it's a patient that we don't see IgM, we only see IgG, of course, that means this patient infection should have been at least a period of 10 to 14 days ago, and IgG is what we are seeing. Then another thing is some new kits that are already being tested. They're already out. So FDA has even approved some of them. Some of them are directed towards neutralizing antibodies, which are actually believed to be protective. So you actually have some kits that what they look at is neutralizing antibodies. What they want to use those ones to find out is in the general population, how many people that have had the infection before have produced neutralizing antibodies. So that will actually tell us whether post-COVID-19, there will be a herd immunity that will be there in the system. That means, the way we now have so many other influenza viruses that we live with every day, is this what possibly will be happening with COVID-19? So once we get more information, I think with the RDTs, when they come out, when we run an assay, we might be able to give the information to someone, not waiting for the 2 weeks interval. Say, if you see IgM at this level, IgG at this level, we may be able to tell you for this patient, he has had the infection and he's recovering. But there's not enough information now to be able to make those judgments based on RDT. But the only way we can get that information is if we are carrying out RDTs now and weighing it together with the clinical scenarios we are seeing. Then maybe in the next 2 or 3 months, we can begin to have proper diagnostic interpretation based on RDT.
Okay, thank you very much, Dr. Princeville. Dr. Salawu, I don't think she's back yet. So we would...
I'm back.
Thank you.
Thank you very much.
It
has been a lovely webinar. Yeah. As the case scenario that was painted in this webinar, they're all emergency cases. So we just have to go ahead. They can take the sample so as to confirm whether the patient has COVID-19. But because it's a decision of life and death, it's an emergency, so the surgery will still go ahead. just that we take necessary precautions, both surgeons and anesthetists. Since we know intubation, especially if the patient is going to, we have to intubate the trachea of the patient, that means we have to, intubation has been classified as an aerosol generating procedure. So we have to take the necessary precaution. Everybody has to have PPE and fully gowned and follow the infection prevention protocol. For elective cases, that's where there might be some adjustment. For elective cases, patients can be screened. I just saw a protocol by a hospital where they said elective cases can continue, but for any patient coming for elective cases, they will screen the patient for the COVID-19 48 hours prior to the procedure. And if the results come out, it will now determine whether it is a procedure that must still go on, if they take necessary precautions, and if it's a case that can be postponed, let the patient be treated first, so as to minimize infecting the population of healthcare workers. And I think this COVID-19 has come to stay for some time. So I think every hospital has to have a protocol. What do we do for elective cases? What do we do for urgent cases? What do we do for emergency cases? We can't shut down everything. So I think we should individualize every hospital to come out with protocol, anesthetic, surgeon, physician, let's speak together and make a protocol. How do we handle elective cases? How do we handle urgent cases? How do we handle emergency cases? So as to minimize infection, especially to the hospital community, the health workers, for them to go home and spread this disease. So I think it will be in a order for every hospital to develop a protocol. There should be a meeting, theater users committee, where it will be deliberated and we look for the necessary precautions to take and take it. I think that's what we need to do right now. Can't continue to shut down everything, and that's my own position about it for now. Thank you very much.
Thank you. Thank you very much, Dr. Salau. I think the important thing is that we're all here as a medical team to save lives. So whatever we do, COVID-19 or no COVID-19, we must take steps to be able to address that. I think we've been able to address the questions that have been put forward. I'm just going to ask that our two presenters give last minute closing remarks so that we can round up. Dr. Princewill, would you like to give the remarks first? Okay. Maybe Dr. Salau, Dr. Salau has spoken. Dr. Wazu, okay, do you want to give any last minute comments?
Mute. Okay, because I was on mute. Okay. Hello, ma.
Yeah, Dr.
Sorry, I was on
I'll
mute.
come back to you. Let's have from Dr. Wazu.
Okay.
Yeah. Yes, please go ahead.
Thank you, ma. Just to close, I think it's very important. There's need for the government to, come together and bring in the necessary bodies so that we can agree on other modalities of testing. There's need for the College of Nigerian Pathologists to be involved in this, not just the laboratory scientists, so that tests could be gotten and tested and validated. Because there is no, it's difficult to work only with PCR in a setting like Nigeria. And right now, the hospitals are all open and working. We can't keep shutting the patients away. So there is need for us to come to the drawing board and decentralize this test so that even hospitals that can use this test. Actually, some hospitals were using their own point of care test kits to help them triage and sort out their patients. And I think that's actually the way to go, because waiting for this test, sometimes you wait 2 days, sometimes the patients even die while waiting for the test. So there is really an urgent need for this to be acted upon. Let the necessary bodies come together and find a way out, pick tests, validate them, and let hospitals have the opportunity to use some of these tests, at least to screen and triage their patients while waiting for a test from PCR, from real-time PCR. Thank you.
Thank you very much. Dr. Princeway?
Thank you very much, Ma. Once again, let me thank the College of Nigerian Pathologists for organizing this. Let me thank the panelists and all those who tuned in for this presentation. I think one way we have to continue is educating. As an aside, I listened to the presentation yesterday and was quite challenged to hear how the CAP in the United States has been a source of information. And because of that, it kind of produces a uniformity in what is being done. While we go ahead and use the RT-PCR, there are some things that are very important, which is why we feel a lot of people, clinicians, pathologists have to come together. We also have to begin to look at how to narrow the diagnostic window, how to do interpretative criteria, since there are people who are testing negative and still coming down with the disease. This is some of the information we must begin to look at critically and get information. Then in the case of the RDT, we must begin to correlate the RDT results. As we are testing them, we must also have where we are correlating them with people's viral load results, people's symptoms, in other words, their presentation and then their clinical history. So we must have our own information that will determine our national protocol, which Dr. Uwezoki has mentioned. We have to tailor something that can reach every center and be available to, even as we say, the basic healthcare facility. Thank you.
Thank you very much. Dr. Salawu, I don't know if you have any comments or you've gone back to theater.
It looks like Salawu's video is off.
Okay. So maybe we'll ask Dr. Lawal to please give his own closing comments.
All right, thank you very much. There's no magic bullets. There's no magic bullets. Even up to now, people are dying in the UK, in America. Well, we are, I don't know, people say maybe God is on our side. We are just waiting to enter that stage. I pray not. Okay, so we need all the help we can get. Dr. Morayo talks about the case scenarios. Yes, life, you must save lives. You must enter that theater. Well, I also want to remind us that, you see, Dr. Salawu is working in the trauma center. They may be well equipped. Just imagine that man in the hospital somewhere, in the private hospital. Do they have the PPE? Can they, and all that they do? Anyway, you find yourself. As at yesterday, I was reading that about 816 health workers in Nigeria have become infected with COVID-19. I think what other countries did is to ensure that their frontline health workers are protected as much as possible. And of course, the PPE, they are still getting infected anyway. So
gets infected or demobilized from work, then would have also had a ripple effect on people getting better. Okay, Dr. Lawal is back. Yeah, so
wow, I don't even know how to end this, but we are there. We are the soldiers in the battlefront, and we try to help ourselves. Pathologists try to help the surgeons. Surgeons try to help us. Try to do PPE. And what is important is consultation. Whenever you are met with a decision that is very hard for you, try and consult others, so that at the end of the day, you save that life, okay? But at the same time, you also save your own life too in the long run. Thank you very much.
Thank you very much. So I would want to thank everyone who's been able to join us today, particularly those who have waited until the end. And also to let you know that this is just the first in a series of engagements that we hope pathologists are going to have with other health workers, other specialties, to be able to let you actually also see the importance or why strengthen the teamwork that is needed for us to be able to provide quality health care to Nigerians or any other person who is seeking help from or seeking a service from the Nigerian health sector. We thank all those who have posted in questions. We thank everyone who has been able to make this first edition a reality. Apologizing for the technical hitches that occurred, and letting you know that all these things will be taken into consideration towards moving the health sector forward. Thank you very much. I don't know if Dr. Lawal has any further comments before we all sign off.
Thank you all panelists. Thank you, my co-speaker, and we can start on. We hope to see you soon with another. And if you have any question you think that would that can be discussed in this kind of forum, please just throw it to us. We're ready to. All hands needs to be on there, either from the education aspect and from the clinical aspect, so that we can all win this battle. Thank you.
Thank you. God bless you. Have a good week. Bye.